Welcome everyone, and this is the ninth lecture of our lecture series. And till date, we have very exciting lectures, and we have received very good feedback throughout, globe. And I'm happy to say that today's lecture is special, special for me because the guest today is the speaker. I have seen him through, from his PhD days to till date. I am well aware about his journey. He has been very, a sharp student from his PhD times. He is Dr. Anurag Agrawal's PhD student who is an IGIB director now. And I have seen this is especially. I would like to, say to PhDs and postdocs. So this is a very inspirational talk for you because I have seen Dr. Tavpritesh Sethi. I can clearly recollect when he joined some flash courses on grant writing and psychom workshops at Welcome Trust. Then he got this early career Welcome Trust DBT fellowship in clinical research, which is very competitive fellowship. After that, he joined IIIT-Delhi. He is also associated with, I think he is still associated, but he has worked with the Stanford University very extensively there. And now he is very well known in computational and data science. So this is very special lecture for me. So before he start, I would like to, read a few, lines about his introduction. So Dr. Tavpritesh Sethi is a physician scientist, as I told you, and an associate professor at Department of Computational Biology, and also founding head of Center of Excellence in Healthcare at Indraprastha Institute of Information Technology, Delhi, which is IIIT-Delhi. He has been a visiting faculty member at Stanford School of Medicine from 2017 to 2019. He has received his MBBS from Government Medical College, Amritsar, PhD from CSR IGIB, New Delhi, and is a recipient of Welcome Trust TBT India Alliance Early Career Fellow Award, MIT TR35 India Young Innovator Award, Fellow of Kavli Foundation of National Academy of Sciences, USA. These are very, uh, uh, well-known awards he received. His area of expertise is computational medicine, and he has built several artificial intelligence solutions for ICUs, COVID-19, and antibiotic resisting. He has done extensive work in during COVID-19. He has published more than 40 articles in international journals. He has been a TEDx speaker, and I would recommend you please go to YouTube and you should listen him as a TEDx speaker. He has delivered several keynote addresses at international events. He also serves as an academic editor for PLOS ONE, Nature Scientific Reports, PHJ, and Journal of Genetics. So with this today, with our special request, he has been agreed to give us a lecture on our lesson learned from building artificial intelligence applications for COVID-19 that are applicable to building resilience to pathogen surveillance for malaria. So this was my special request to him that he will also touch upon malaria and other infectious diseases, the gap and opportunities for agile data and AI models to guide healthcare response in the country will be discussed during this talk. And I'm very hopeful that everyone will join this wonderful lecture. And before the lecture, Tavpritesh, for your information, generally I received, appreciation messages after the talk, but I received, lots of messages before your talk, and in that, some big names are included. So, all yours, Tavpritesh, please start.
Thank you so much, Dr. Sharma, for that very kind introduction and for bringing back the memories of early days psychom workshops. And I would say very formative years of my time where a lot of support came from a lot of colleagues from the Alliance, and now very happy to be speaking to the audience through this forum of ICMR, MERA-India. So thank you very much for inviting me here. And I will be talking about building pathogen surveillance and healthcare preparedness with data and AI. And mostly my work has been in the space of infectious diseases, um, sepsis, ICUs, more recently in the last couple of years around COVID. But I truly believe that that COVID is just an opportunity for us to build preparedness for vector-borne diseases, malaria, and in general infectious disease preparedness in the country, because there's a lot of morbidity and mortality because of these diseases. So I will definitely try to touch upon the areas of intersection which I believe could be important and can be used to build malarial or malaria preparedness and prevention as well in the country. So with that, I'll just start with the lessons that we have learned from COVID, because I think that has been on our minds and on our plate since the last 2 years. It's still going on. So when we started out, we basically realized that the pandemic response needs to at least have these three components, which we found need to be addressed. The gaps, as we saw. The first gap is the data gap. And most of us know that data platforms and data exchange in healthcare is a big challenge. And that is not just true for India, that is true globally, overall the world. Exchange of healthcare information timely and in an agile manner is a major challenge. Partly because it is very sensitive data, but mostly because healthcare systems have been slightly lagging in the adoption of technologies and in the adoption of data and AI systems and other areas like finance. These have gone much beyond. But also it is an opportunity right now for healthcare to leapfrog, because a lot of other developments that have happened with data and AI, we can actually piggyback on the top of these and see how healthcare systems can be moved forward. It's also a time-consuming process. There's a lot of drudgery which we think can be taken away. For example, doctors, if they have to type a lot of records, or if there's a data entry operator who has to do a lot of standardization work, what can technology do to actually take away some of that drudgery, and how can AI help is a very active area of work. There's also a knowledge gap, which means that there are very few skilled people who are trained at the interface of healthcare and data and AI ML. Things are changing. We've seen that a lot more younger people, many of you may be here and may be interested in actually creating solutions that can leverage data and piggyback on that. But more people are needed. I mean, we can't just have enough good people who are trained at this interface of bridging of skills. And we are happy to say that during these last few years, our lab and our center has been contributing to training younger people along that lines as well. Thirdly, for pandemic preparedness, infectious disease preparedness, the gap that exists is that research needs to connect with, it has to help the policy making and guide policy making so that effective actions can be taken. And so we realized that these three gaps existed in the pandemic scenario, in general exist for pathogen surveillance and for general healthcare systems. So we are very happy that over the last couple of years, we were able to address some of these gaps, very small contributions, but we were able to address some of these gaps, and I'll be talking along those lines in the next 35-40 minutes or so that we have time for questions also. So the first project that I would like to talk about is what we call the integrated federated health platform. It started right at the beginning, the discussion started right at the beginning of the pandemic, that data exchange and data platforms need to be there. There's a lot of expertise in our country. There's a lot of expertise in the hospitals. There's a lot of expertise in research areas, researchers building lots of solutions. But for a pandemic response or an infectious disease systems preparedness, these need to talk to each other and build data exchange mechanisms so that timely and agile data systems can be created. This is a big challenge, as you would understand. Even now, AIIMS wants to exchange some data, let's say, with another hospital, let's say Apollo or Max. These might look very different because these are completely different systems, right? So what we proposed was that we should be able to build a federated health system and a platform where we don't code any data. We are a research and an academic institution, but can we provide handshake mechanisms where some of this can be digitized, formatted, standardized in ways where data exchange can happen in more seamless fashion? And you would realize why that is so important for infectious diseases, right? If we are seeing a resurgence of some infectious disease, we need to be prepared. These hospitals, for example, need to share the information, and then we need to be prepared together. And then the goal was to build AI-based systems on the top of these data exchange mechanisms. And here is, I'm just showing 3 examples, which one is called strain flow, which uses genomic information to predict emerging strains. And I'll talk about that in a little bit more detail in the coming slides. Evidence flow is on using AI to mine evidence and synthesize evidence from the growing scientific literature. And then there's resource allocation. Now, if you think about allocating vaccines or allocating anti-malarial drugs, although these are not expensive, but think about any situation where resource allocation is a problem, right? Ventilators, oxygen, even personnel. How can we build solutions that can guide that? So that was the overarching goal of this particular project. This was supported from the Principal Scientific Advisor's Office and is a Delhi Science and Technology Cluster project. So essentially, in this project, we are collaborating with CSIR IGIB, AIIMS, IIT-Delhi, Ashoka University, JNU, and we are leading from IIIT the AI/ML in healthcare vertical, where our goal was to provide these data backbones and the AI solutions. And then we also realized that hospital data is one kind of data, research data, but there's also a lot of publicly available information that we as researchers many times do not mine. For example, in this particular work, we mined about 10,000 data sets, out of which 6,000 were found to be good quality. And this number is growing because every day new research data gets deposited. And you may be aware that is because most of the publications these days require the data to be deposited in some repositories like Zenodo or Mendeley or Data.Dryad, DBT data repositories for DBT supported projects and so on. And I think ICMR is also now having its own repository. So how can we leverage open data sets like these to triangulate insights, right? And this work actually started, this thinking started very long back when I was finishing my PhD. We were actually merging data sets at different resolutions from the Indian settings and trying to derive insights, and we found that AI could help in that line. So now we are just extending that line of approach. We have been doing that over the last few years for many diseases, and I'll show the strain flow example, which is for COVID also. But the goal here is, can we build systems that can, for example, understand what the metadata point for the data, and then build schemas in a more automated fashion so that we can combine these data sets together to build evidence from data. And this is the hospital data exchange mechanism that I was talking about. So we are basically working right now in the Delhi ecosystem, but we are continuously speaking with, through the DRIVE, the Science and Technology Cluster project, speaking with other hospitals which are beyond Delhi. Like currently we're speaking with AIIMS and Maulana Azad to see if we can actually get these data exchange mechanisms to actually be used in these hospitals. one of the key things in this is that this is NDHM compliant, which means that the National Digital Health Mission's APIs were used to create these data exchange mechanisms. That implies that, as now I think we all know in this current budget, it was announced that the Universal Health Interface is being rolled out. So most of us already have health IDs. Going forward, these will be linked to longitudinal health information and also insurance payments, etc. for in the PMJAY. So it will become increasingly more important, right? So I mean, if we think about starting a research project which will collect data at the start of pandemic, it will happen, but it will happen in its own sweet time. In the meanwhile, if you build engineering systems which can actually sit on the top of routine data that are being generated either in the hospitals or in the research settings, that engineering work also we believe is a very important part of building pathogen surveillance and preparedness systems. But then now I'll move to showing some research use cases and examples, scientific examples on how would we use these kind of different heterogeneous data sets, right, which might be from very different sources, different sites, very different sort of formats, etc., and to enable agile data-based predictions. So this is a paper which which is in revision right now, but the preprint is available and a dashboard is also available. All our COVID-19 research was made open right from day one. So the architectures, papers, software, I mean, we made it a policy that for COVID-19, everything was open. So this preprint is on genomic surveillance of COVID-19 variants with language modeling and machine learning. And as you will see in a short while, why this is applicable, for example, for malaria vaccine research as well. And we are thinking on those lines on not only malaria, but how can it actually enable some of those directions. But the key sort of underlying principle here is that public repositories were being created. For example, there is GISAID repository, which has so far, I think, more than 3 million sequences that have been deposited by countries across the world. And these sequences have been used in building models and analyzing the sequences. And there's many resources like NextStrain, GISAID website itself, which shows how the strains and variants have been emerging. So we went a little forward by asking this question that can we read the sequences of the spike region of the SARS-CoV-2 virus like a book, right? And basically why we say that, because the current ways of analyzing these data, they do not consider long range interactions, whereas language models are very advanced. If you think about it, when we are typing a word in Google search or in Gmail, it suggests the next word because these models have been trained on very large internet scale and models that basically learn how the context drives a certain word being present or absent, right? So now you can think about these codons and a lot of context that we wanted to learn from these spike region. And so we started very simple. I mean, it's simpler language models which are based on deep learning and neural networks. But later I'll show the very advanced kind of models also, which have very interesting findings. So essentially, these models, what do they capture? They, in a sense, are trying to capture the underlying grammar of the mutations or changes that are happening in the in these sequences, right? Because there's some patterns that may be long range and can be captured in these sequences. So we were using these sequences to train and then validate and test in 17 different countries, as you can see here. And then what we found was that once you have actually captured, you have coded this sequence in the underlying grammar space. And I'm using this word grammar more loosely because just making that connect with the English language, right? But you can think about, is there a set of co-occurring changes that are happening together in these in the spike region, and then you can say that each sequence will occupy a certain space in that underlying grammar, right? For example, in word models, if we think about texts written by Shakespeare, texts written by Kalidas, texts written by some modern authors, right? They will fall in their own spaces. That's exactly what we did here. That how do these sequences fall in their own spaces based upon these features, and we were able to reconstruct the phylogenetic analysis of these sequences, and it was surprising to us that it, in a completely de novo analysis, captured the temporal as well as the spatial patterns within the spike region changes over time. And then we went one step further to ask a question. Okay, it's okay to capture the phylogenetic relationships and spatial relationships. Now we have embedded these sequences in some 36-dimensional underlying space, mathematical space, right? Which essentially compresses that 1230 long spike region into like 36 dimensions, very compressed grammar space. And then we ask, are there certain dimensions which can actually predict in the future? How may the cases change? And for that, we did mathematical analysis like entropy, right? So, and we found that, yes, there were dimensions on the right-hand side. You can see in this figure that there are certain dimensions, and this is dimension number 32, for which the entropy actually went up and then started falling down up to 2 months ahead of time before the cases went up. And this was found consistently in many countries and validated by our models. And if you think about it, this is biologically plausible because the virus is going in these explore-exploit cycles. It's exploring the space of mutations. Now, when it finds something, it gets established. And those changes actually happen much before the case series or the observation of cases actually starts showing up. So that's why this leads this time, and that's where the signal is actually coming from. So we actually just encoded this in a nice machine learning model, this understanding, and we could see that, and you can see here the dimension 32 entropy following this pattern, very similar pattern across many different countries here, all of which are significant. And then we built the models for asking how would the cases look like in the next 2 months, right? So we did causal analysis to see lead lag, that many dimensions may not lead, right? Some may just lag, which means that mutations happening as cases get established. So this led us to actually create a dashboard which is available publicly. And as I said, we are in the second revision, so hopefully the paper should be available soon. But the dashboard talks about how the cases may change in the next couple of months in these many countries. I'm just showing India here. What is noteworthy, what I would say here is that we cannot predict the exact number of cases. That's a disclaimer because we believe that this is just one signal, right? If you think about infectious diseases, these may be many different things, people moving, right? Events happening, holidays happening, and then so many other things. But strains is just one part of it. So, but we can actually capture the trends in which direction it is going. So that's what we were able to say, and we were able to capture that for the Delta as well as for the Omicron. At the end of October, we actually said that we do see a increase towards December, and we didn't know that Omicron was there at that point of time in India or not, but we did see this early change at that point of time. These are also biologically validated. Now on the right hand side, you can see that we went back and asked the question that what are those 36 dimensions, those mathematical dimensions actually biologically meaning? So we could do a simple analysis where we saw that what are the codons which are weighing highest along each of those dimensions. And when we looked back, it was the same kind of codons that which were important for Delta, but then there were also more. And what we could do is we could make a model out of those relationships, which could predict the cases. So that that was very encouraging for us. But what we lost here was these models could not give us the position information. If you have to design vaccines, if you have to design drugs, or if you have to say how well will it bind to the receptor, it's difficult to say because this is a more abstracted model. Things are happening in combinations, right? So we asked the next question about, can we use even more advanced language models which can then give us positional information also. And just as an example, on the left, I'm showing just showing how these models work. This is called the attention mechanism. And these models basically pay attention to the entire context before predicting a certain word, right? So if you, for example, look at the sentence, the animal didn't cross the street because it was too tired. Now, how does the model know that the word it here refers to the animal and not the street? I could change just one word in the sentence to say the animal didn't cross the street because it was too wide. Now the word it will actually refer to street, right? But here you can see that the model is actually capturing that it is referring to the animal. This block is coming up. So this is, I mean, these are extremely expensive models to train. The good thing is that large companies, all large companies have trained these kind of models and made it available to the public, but trained on internet scale language data sets. So here we reused these models and fine-tuned them on genome sequences, asking the same question that there can we actually fine-tune it to a completely different setting. And to our surprise, we did find that in the landscape, we call it the attention landscape. In the attention landscape spike region, we do see that similar hubs of attention are there, right? So every codon is not behaving equally when basically changes are happening in these sequences. And there are hubs of attention that can guide where might be the next change, or where should we make a change to create effective vaccines or better drugs, or to understand how receptor binding may happen. Right, so this is work in progress. We haven't yet put it out, but very early results are very encouraging. We call it the Covert model. And you can see already that this is the previous model that I was showing, strain flow. And this is Covert. And Covert is actually capturing a lot of much more fine-grained information about these variants. Now, what does it allow us to do? Right, so it's one thing to predict what the future cases may look like. But we believe that there is a much bigger opportunity here in general for infectious diseases. And the opportunity is that the language models have been basically they have been trained on a spike region of viral sequences. And if we pick any other similar viruses and we actually start moving them to other pathogens, right, we should be able to capture the overarching principles, at least within the families of pathogens, on what makes them either highly virulent or highly transmissible or pathogenic, right, or having high mortality, or how can we actually design better drugs. So we actually consider this to be a in silico molecular surgery kind of a platform, where if I am able to actually change a certain codon, how would other locations may change, right? And can I actually guide better insights by using this? So this is still work in progress, as I said, but I think that is what we are very excited about going forward with these kind of models. And we all know that it was very encouraging when in October last year, the first vaccine for Falciparum was actually approved for children at risk. And if you actually go back and look at how these vaccines are being developed, right now we know mRNA vaccines have been important for COVID, but essentially we know that, for example, these subunit vaccines, they are taking this genomic information into account when we are designing such candidate molecules, right? So I think it's a big opportunity for us, and especially for wherever these kind of data sets are available, or to actually create resources where such kind of data sets are available. We know that there is pathogen resources maintained by NCBI. There is GISAID, there's a bunch of others. So I think there's a lot of opportunity for using AI-based pathogen surveillance looking at genomic data sets. That's, I believe, one part of the talk that I wanted to convey, that how genomics and AI can come together to guide surveillance and for better drug design and vaccine design and so on. That will, so with that, I'll transition into the next part of my talk, which is more on the lines of public health interventions and evidence, where that evidence flow framework and public health comes in, because the response has to be multi-pronged. And in this, basically, where we started this line was actually in our project in the ICU settings, which was supported by the Welcome to Rescue India Alliance, which we call the Safe ICU project. We realized that a lot of readmissions to the ICUs happen from the walled part of Delhi, and where hygiene issues are obviously more prevalent. And you can also think about malaria and messaging about it being so important in preventing it. So we realized that we can predict sepsis or infections in the ICU, but a lot of it actually happens in the community. What can we do about it? So we started with a very simple informational app, which we called Wash Karo. The key idea being provide the right information to the right people in the right format at the right time. Now, WHO puts out a lot of information, Ministry of Health and Family Welfare puts out a lot of information, but are the common people who don't even read English reading it? Even doctors don't read it, right? So how can we actually make this information more accessible to people who need it the most? So we said that we can build a framework, at least for the Android phone users. And I would say outright that basically not everybody uses an Android phone. We still have a lot of population which actually uses the featured phones. But for this, basically what we said that can we use AI to read source texts and also match it with what is happening in the news around the world, and basically match these by developing these AI-based filtering systems, which goes through a couple of processes called summarization and then similarity mapping, etc. So think about this as an advanced filter, which says, oh, WHO says this, and this news is on the same lines as that, right? Because people are not probably interested in WHO reports, but they are interested in news. And then basically we computed about 30 different metrics to see which metric validated by a team of human experts, to see which metric actually does this best filtering. And once you were able to do that, we were able to actually pull out the matched articles and use translation and text-to-speech APIs in the app to provide that in the Wash Karo app. And one thing that we just put in there, we didn't realize, although we thought about it, but didn't really pay a lot of attention to that. People can give feedback by thumbs up and thumbs down, right? If that information was relevant or not. So what we found was that Wash Karo engine actually became very relevant when COVID struck India. So we quickly repositioned it for COVID, and we were the first, I think, AI driven public health infodemic application at that point of time. We actually were online on 14th of March 2020, right? I think within a couple of weeks when we knew that COVID was now in India. So, but interestingly, what we found was that people giving thumbs up and thumbs down actually led to our AI thresholds improving over time, right? So relevant count actually went up over time with the users giving labels as thumbs up or thumbs down. Irrelevant count started falling. Unfortunately, I think we were online with COVID for only 2.5 months because of the government directives that only governments can spread the COVID information. But during that time, we were able to find very insightful things about this. That our original hypothesis that, for example, we need to segment out uh, the ways in which information needs to be provided to the common public. Think about it as malaria, tuberculosis, COVID, sepsis, all of this, all infectious disease. We need better public health information systems that can be tailored to the kind of people they're serving. And very simple insights during those 2.5 months were that more females were engaging with the app in Hindi than in English. Okay, I mean, so this is intuitive, but we had the data now on this, that how to design better systems, right? And also in general, males interacting with apps more than females, and more in English. Tells us about some gender divide, tells us how should we build more inclusive apps for public health and so on. So we appealed to Google that we were before COVID, and our app is back online with not for COVID but for tuberculosis, and we are basically addressing in the pilot study in Delhi, actually assessing the efficacy of this in vulnerable populations where this kind of information is actually very much needed. And I think so. I think one of the key areas when we work with these is that we collect all the information about health factors, and this is as much applicable to, you can think about Washkar or malaria having similar features, and learning over time that how the incidence rates have changed over time, or how have people become more aware of measures around these, right? So basically these can be useful for these kind of settings. This is published recently in scientific reports. Another work that was published, I think, early on in the pandemic, but the reason I'm showing this is why public health messaging is an important part of pandemic response. People's behaviors, right, are very important to guide the effective policy and response. And in this work, what we did was we used language models again to understand how the government bulletins and COVID tweets were actually coupled to each other in some of these lexical categories like fear, hygiene, health, medical emergency, occupation, etc. And we found some interesting patterns that changed across states, both in the first wave and the Delta wave in India. And yeah, I'll skip this part. But what we were able to find was that there was a very tight coupling between these lexical categories like sadness, nervousness, confusion, misinformation, right? And basically the responses towards that, which means that to design better responses, we need to understand what is vaccine hesitancy, what are the misinformation trends about a given pathogen in the community. Are people hesitant to take an anti-malarial, right, or other interventions and so on? Okay, so these are just examples. I mean, these kind of systems can be built on demand, right? And that's the power of AI, where we can specify lexical categories and then essentially understand what are the trends along those lines. Okay, so these are just significances showing that some things government was actually the driver for some of these lexical categories. For some other things, the public was a driver for those lexical categories. If you look at the time series coupling analysis, right? So ideally, I think so. That's a good sign that there's a both two-way communication, and essentially better responses can be designed using those. I know I am already at 3:40, so I'll very quickly skip how we also use similar approaches to build models that track evidence across literature, right? So we talked about language models for reading sequences from genomes, language models for public health, for essentially looking at what messaging systems need to be developed, but also what researchers can actually gather from rapidly expanding literature. And this was a big challenge, if you remember, hydroxychloroquine, remdesivir, vaccine hesitancy, all of this was a big challenge to keep abreast of because of the literature that was pouring in for COVID. So we asked the question, can we use these kind of models to track evidence that emerges in a given area? And again, this is not limited to COVID. Now we are actually doing it for other infectious diseases and seeing what is actually what can be predicted about research evidence coming up. But a very simple approach that we basically said that the themes that will become important over time will gather weight, and these will actually look something like this on the right hand side. It's called a Lugel diagram. So words that form very strong connections over time, and these connections become heavier and heavier, right? And they become important over time. We can use these connections to predict what may happen next. And this recently again got accepted in JMIR. It's to appear in JMIR, I think in the next in the March issue. But what we do here is essentially we track these, and you can see that early in August 2020, our evidence capturing model actually told that it is a systemic disease, right? COVID is not just a pneumonia. It is a systemic disorder with a lot of thromboembolic complications, thrombosis, acute kidney injury, coagulopathies, and so on. This is much before talks even started about hesitancy about vaccine and blood clotting, etc. And then basically we tracked it over time. And in January 2021, we saw neurological issues and psychiatric issues emerge and so on. Evidence about that and long sequelae of COVID. Again, this is something which, as I said, this is a use case for COVID, but we believe is an important tool for researchers to see and assess what how can we strengthen evidence about a certain pathogen and start designing our experiments along those lines or conducting studies along those lines. So what are the opportunities in the clinical settings, right? So this project, I'll be quick, I know time is short, but in our Safe ICU project, which, as I mentioned, was supported from the Wellcome to SDBT India Alliance, we actually built ICU predictive systems where we said that there's a window of opportunity before a patient crashes with some outcome like shock, sepsis, or multiple organ failure, etc. And that can be leveraged by using the big data that gets generated in the ICU. And that big data is routinely lost every 24 to 48 hours. The monitors that show the heart rate, oxygen saturation, pulse rate, respiratory rate, the data gets overwritten because nobody knows what to do with it. Storage is not there, right? And so on. So in this project, we said we will actually warehouse these data and build predictive models. So far, we have actually we are at 1.5 million patient hours of continuously monitored data over the last 6 years. And we started very lean with building very lean systems, for example, quality initiatives. How good is the data that is coming from each bed, right? If we look at it here, you can see maybe some sensor came off, or maybe there was a mismatch between what is on the monitor and what is put in the treatment chart and so on. So those are seen as red bars here. How was the antibiotic usage? What are the other features? How is the oxygen saturation range? So we built by actually building these very simple, straightforward dashboards for the clinicians to generate value for guiding some of these very simple clinical things. But then we said, can we now actually start predicting outcomes? Which means that can we start looking at this data, which is before the black line, right? Heart rate, oxygen saturation, respiratory rate, pulse rate, and start predicting what may happen at 6 hours, 12 hours ahead of time, right? So for that, we combined, this was a multimodal setting. So we actually combined images with text and vitals. And we were able to show that more than 12 hours ahead of time, we were able to predict with more than 75% positive predictive value and accuracy critical outcomes like shock, which is one of the major killer. Right now, shock happens in dengue. Shock also happens in severe malaria. Right, many patients actually collapse because of this, and so on. So it's a very common complication for sepsis and even trauma. So, and this was built on very simple hypothesis, clinical hypothesis, that in shock there are some physiological features that we should observe, and then we automated that process. And now we actually are have taken this forward to a bigger level, because maybe, I mean, so if we built models for AIMS, right, they may not work at different other settings. So this paper is under revision, but the preprint is out, where we actually evaluated these models for more than 200 different ICUs, major of which are not from India, they're from the US settings, because these data sets, as I said, are large data, hard to get, expensive data to store, etc. But we were able to actually build models that could generalize across pediatric to adult settings, and also in different geographies, and also in different kinds of ICUs. And we were able to prospectively validate these models in the pediatric ICU at AIMS, which means that essentially we said that, okay, we will freeze our models, test them, and then we'll prospectively validate to see if they actually work. And the paper title is Generalized Prediction of Hemodynamic Shock in Intensive Care Units. And you can see that different kinds of ICUs, for example, coronary care, cardiac surgery, cardiothoracic, cardiac, medical, surgical, neuro ICU, surgical ICU, and so on. These are different patterns of prediction of one simple outcome, which is shock, which tells us that there's a lot of scope, and there's a lot of challenges also if we have to actually generalize our models in a variety of settings. So currently, after this paper, what we are doing is we are working on different resolutions of data to actually start seeing if AI can actually help some less resource intense settings where these kind of data may not be available at every minute resolution, or even every second resolution as we had for the AIMS, or we built for the AIMS ICU. So can we actually compress it to like 1 hour the resolution, and start having similar predictions? But that's an active area of research that we are currently involved in. Finally, I'll end my talk here by saying that a big opportunity of AI is in the space of drug discovery. And many of you would know AlphaFold 2 is an algorithm from Google DeepMind, which recently broke all the records in the CASP challenge for protein folding, and somewhat connects to what I talked about earlier in the embeddings kind of model. But a lot of research is currently happening in the space of drug design and vaccine design for pathogens using these kind of models, which make use of an approach called reinforcement learning. Now, the reinforcement learning approach is a similar approach which is used for training Mario players to play video games on their own, right? Or proteins to fold, and so on. And we asked a question: can similar approaches be used for resource allocation problem, right? How much vaccine should be sent where? And I would confess that this problem, I think now, is not applicable as we are standing now, because when we posed this problem, we were in August of 2020, and we said that when the vaccine phase 2 trials were announced, And you said when the vaccine comes out, it might be scarce. And if it is scarce, how would it be allocated? Can it be guided by the context, right, and of the states in India and so on? But the good thing is that it still applies to everything: beds, ventilators, oxygen, uh, uh, resources that need to be uh, created for any infectious disease preparedness system, any epidemic, or any chronic endemic condition as well. So the model that we built here was a reinforcement learning based approach, where we said this is the context. Now you can think about context can be certain geographical areas, it could be certain um, uh, health system access, recovery rate, hospital beds, etc. And these would guide how should resources be allocated. And we were able to show at that point of time that we would always prevent a positive number of cases than a naive strategy. And why I say a positive number, because it will depend upon which stage of the epidemic or endemic diseases are we in, right? So what we were able to show that potential cases prevented could be always a positive number if we took an approach that just does this optimization. As I said, now we know a lot more, right? And so this model is outdated. It's still in third revision. So I think by the time the paper will be out, probably we are just going to say that this architecture will be, this is openly available. So the architecture will be open sourced and can be used for other endemic or epidemic problems. But essentially, it creates a framework in which resource allocation can be addressed using AI. So to summarize, basically, I would say that health system preparedness for pathogens, be it endemic, be it epidemic, be it pandemic, right? These can be made more agile and multi-pronged. You can think about if we are trying to mitigate malaria in the endemic disease, it needs to be multi-pronged, from messaging systems uh, to having better treatment regimes, to drug discovery, to even vaccines, right, as they become available and so on. So, and also predictive trends. Can we predict the trends using AI/ML, the kind of trends that, for example, I showed earlier in the COVID prediction, right? I think more and more preparedness systems will actually triangulate this information. What is the sequence data saying? What is the case data saying? What is the social media signal saying, right? Because people may start scrambling for something, and basically that might be a signal that things are going south on ground and so on. So these have been multi-pronged systems, and there will be a lot of components like public health interventions, behaviors, resource allocation, and of course, clinical decision making in the ICUs, hospital settings that can predict outcomes and better patient decisions is something that will be very important. So I'll stop here, and not before acknowledging all my funding support and also my wonderful team, which has been a part of all this work. I mean, so things that I'm speaking actually are a lot of wonderful work created by our team and our collaborators. So I'm happy to take questions and engage. Thank you so much.
Thank you so much, Tavpritesh, for this wonderful lecture. And I'm sure this lecture has been very much has been very much useful for malaria researchers as well, because most of our audience is malaria people here.
Right.
And I mean, this is really exciting to see, the lots of combination, and the there's no limit to you just need you have the data, and lots of wonders can be done. And this is sort of magic things, right? So if you permit, can I take some questions?
Absolutely, happy to do that. Thank you.
Okay. So using this LP NLP building models like coverts is fascinating. So are you integrating only database data of sequencing or text mining data from published and unpublished records? If yes, how are you coping with challenges of data integration and structuring as they are apparent in changing existing available model design?
That's a wonderful question. Absolutely, great question. So we think about these as levels of data. So there is summary insights, which, for example, researchers put out in literature, in research studies, which these models can mine. Then researchers put out data sets in repositories, or even, for example, the GISAID repository and the Johns Hopkins University and ICMR repositories and so on, where researchers contribute data sets. And along with data sets, there are descriptions and code books. That is level 2, where you are now getting slightly more closer to the data, right? By actually training word models on data set descriptions. And so the first sort of part of the talk where I showed that 6,000 data sets, what we did there was actually we mined the descriptions of these data sets. Um, as of now. And we said what data sets are living close together in the description space. But as you are saying, I think that's exactly the next step, which is the most challenging, but also the most important step, that once you know that these data sets can be integrated, right? Actually integrating them needs structuring, harmonization, standardization, and that's where we are currently working on by the use of ontologies. That is work in progress. And but yeah, so there also we are using these kind of models to see if we can actually create, we call it the COVID-19 data commons approach, similar to what data commons actually do. That can we actually create a knowledge graph from these data sets where integration can happen. But that is just the beginning. It's a very challenging problem, and we are applying state-of-the-art computational methods. But as you would know, just computation is not enough. We need experts to build these knowledge graphs also. So that is work in progress, but that's an extremely important question.
Okay. Another is how you controlled or assessed accuracy of your ML AI model predictions through text mining, as finding from published or unpublished papers can be influenced by the author's conflict of interest.
Again, a great question. In fact, one of the reviewers actually, so yeah, so there's author's conflict of interest, but there's also like data repository. So what did we do here? We said that we will actually go by WHO vetted publications. For these can be preprints or these can be published peer-reviewed papers. But we'll look at the database that is hosted by the WHO and vetted. There's also other data sources like COD19 data set, which is a very famous data set that can be used, but it doesn't have human vetting, right? Then you can also look at patent sources, which will be completely those were actually present in the WHO, but these can be completely absent from COD19, etc. So it is very important that the biases that could creep in based upon what was the data sort of mining approach. And our response to that was basically we were going by the approach that we want to go by vetted articles, human vetted articles. But then for example, the reviewers were of the concern that we don't know what, even though if it is WHO, we don't exactly know what they were thinking and why some studies were excluded, right? So there will be biases, there will be biases that happen due to negative results, right? Not ever coming up in publications, which is a bigger challenge. And that is a acknowledgement of this kind of literature-based approach that we clearly are saying that we are probably missing out on a lot of studies which may have negative results, right? So, but we are just trying to capture that early signal which is being gained. We are not capturing everything. So we are just capturing that early signal which evidence is gathering about and we can be predictive about. But as you said, there are biases in the way these data sets are sort of generated, or even if we write our own data repository mechanisms, scraping mechanisms, those would have publication bias, etc., which is hard to avoid. You're muted, Dr. Sharma. Can't hear you.
Okay, sorry. So we have with us Dr. Manju Rahi. She's, I think you know her. She's a senior scientist in ICMR headquarters and program officer for MERA-India as well. She has questions. Bhavna, can you give the access to Dr. Rahi?
I think I have it now. It's unmuted. I hope I'm audible.
Yes, Dr. Manju.
Thank you, and thank you for a lovely lecture, which I confess to Sachin multiple times. I am technologically very, very compromised, and I have very naive and very ignorant question. And I was just thinking when you were presenting AIMS data of how you have mined the ICU data, which actually gets lost. I was wondering, I was reading some papers many years ago. Institutions like AIMS and these referral hospitals, radiological departments, they have, because storage capacity is so limited, even in corporate hospitals, only few years, images, PET scans, mammograms, radiographs, all these are saved. The images are for very limited time. If those could be mined and you could see a trend of, rising cancers, how many women are presenting for mammogram, how many are them in the early stage of cancers, and you can compare it with different years. Like now people are more aware, they are coming in early years of detection rather than later on. But this data is never looked into systematically. Somebody was trying to correlate oral cancers, the trend of oral cancers, seeing these kind of reports and the advent of, how these pouches of pan masala have come up. So they correlated the oral cancers have risen since these pouches are available so cheaply and every nukkad has it. So people have easy access. And even correlation of ultrasound facility availability and falling of sex ratio, because it's easily accessible. Now people can go for female feticide very easily. So that's how they were correlating, mining these data from the radiological centers. So if you have a collaboration with AIMS, I was just randomly thinking this is nothing to do with malaria, and I don't understand machine learning. Some of it for malaria, yes. But if these kind of, when I was talking to my husband who works in a Max hospital, I can't retrieve my own report, my X-ray or my CT scan, MRI underwent. I can't retrieve them after a few years. But maybe you can expand the capacity. Or these large hospitals in Delhi, they lose gold mine of data because of because they don't need it. But if these are dug into, you can come up with some disease trends, especially in the urban areas where cancers and these non-communicable diseases are increasing very heavily. I know you were interested in sepsis, and you try to correlate with the geographical area of Delhi, like older Delhi, whatever. So you got my point, right? If you could mine those data. My second question would be, in COVID times, I work in ICMR, so there were many requests. Many groups were making these apps for reading X-rays for COVID manifestation for pneumonia. Without a doctor looking at an X-ray, if an app or something can, using AI, could pick up lesions of COVID for lower lobe pneumonia or whatever, and they could diagnose. Even though government rubbish it, that should not be seen as a. But my lot of clinician friends, despite RT-PCR negative, the clinical symptoms are of COVID, they would treat for COVID, and that is valid because sensitivity of PCR is only 70%. So do you really feel that these apps have some value in clinical diagnosis?
So the first question, Dr. Manju, yes, absolutely. I think what you suggested is that these insights need to be triangulated, and that's what basically we believe is the next kind of public health system that basically will be put into place. That in a federated health platform, that exactly was the idea, that there is some context of Delhi or of an urban region, and then there are these multiple repositories. For example, AIMS, as you said, stores a lot of data. Now, if there's a network and opportunities and also the frameworks to make these data persistent over a longer period of time. It is a gold mine, as you said, to actually understand the disease systems. And I believe that is where we should be moving as a country and are moving as a country, because with the health ID and the interfaces that are coming up, the longitudinal records that are potentially going to be available, and also the NDHM frameworks, hopefully, I mean, that all structuring of data will happen in a more federated manner, where data sets will be mined for such kind of insights. With AIMS, yes, we do have collaborations with the departments, with for example, the IRCH for cancer and other departments as well. I would confess that we have not looked at large-scale imaging data banks from AIMS, but I'm a part of those couple of discussions, and I think that's definitely a strong area where expertise should be built. Regarding the COVID apps, I think it is of importance. But also, my personal thing is that my personal viewpoint is that there's a lot of metadata that can also add value to the decisions that are coming from these apps, for whether it is a COVID pneumonia, is it a lobar pneumonia, is it septic or fungal. So there are patterns. There are very clear patterns that can be different. But then for having low false positive and low false negative rates, which is always a challenge, I think a lot of information from other sources can also be brought in, and that could be more from metadata. So in general, I would say yes, it's a very potential space. As you said, that it has been looked at slightly from the. It has been looked at skeptically, mostly because I think the generalization of these models is a major issue, and that is where we believe that more studies that can look at generalized predictions across centers, across populations, age groups, stages of disease. I think that's where these models typically tend to fall through the net.
Thank you.
Thank you so much.
Okay, I think Dr. Praveen Bharti is also there with Dr. Rahi. Dr. Bharti is a senior scientist at NMR. Yes, Dr. Bharti.
Thank you, Dr. Sachin, and thank you, Dr. Sethi, for a very informative talks. So I have a few doubts about the AI and prediction of disease and trend of the disease prediction. So in the case of COVID, it is easy because only the pathogen and host. But in the case of malaria, there is another host, that host vector pathogen, as well as the environmental factor. So once the factor is increasing, how it is going to affect the prediction of the trend of the disease?
Absolutely great question, Dr. Bharti. It is not that big a challenge. I did not show some data from our early 2015, my PhD time work, where basically a lot of different factors, if we are actually having that kind of data available on different factors, it is not really too difficult to integrate, to go from just host pathogen to an intermediate reservoir and add those factors as well into a model to see trends that how they may emerge. And they are, actually, it might be able to actually pinpoint the change. So that is completely possible. If we have, for example, if we have monitoring data for larval breeding larvae, etc. Certainly, those data as a layer can be added in the context and can certainly be added onto the prediction models. And I know many colleagues, friends who actually do similar kind of work with more standard epidemiological models. But we can, for example, think there's no limit to adding the AI kind of layering on top of it.
Thank you.
Thank you, Dr. Bharti. Sure, Dr. Sachin, but you're muted.
If you allow one more question, please.
Sure. Sure.
Question. So this is from a team member. Dr. Amit Kumar is asking, can we predict mutations which may lead to a strain with more severity? What parameters one should consider to perform such study?
That's again a very important question. So what I showed in the second part of the strain flow, where we were able to actually look at the gene, the sequence, the region, location, and the goal there is actually to see what are the regions which are under higher tension, and can we predict that if a change occurs in that, what other mutations may emerge, and then downstream. So that part of experimentation is complete. What is not yet complete at our end is the study where we show that if we conduct this in silico mutations actually, and then how would the the biophysical properties, or for example, binding energies change to say that it will escape immunity or be more pathogenic or be more transmissible. Those experiments we have not done yet, but I'm in communication with a colleague who does those biophysical experiments. Having said that, there is a startup in South Africa, I'm forgetting the name, I think DPI, or I'm forgetting the name right now, which exactly did similar kind of an experiment, and they showed at the amino acid level model that what changes in the amino acid can be predicted and how may it lead to increase in at least transmissibility, if not virulence or pathogenicity, because we know now in Omicron that we observed higher transmissibility, but not necessarily increased virulence or pathogenicity. So I think those outcomes will always be guided by experts to say that what is the vaccination rate, what is the vaccine escape, immune escape possible, and those factors would need to be also brought in.
Okay. Okay. I think Bhavna wants to ask some question. Yes, Bhavna, from the chat box.
So, I mean, this is something even I would like to know, that how would you be able to get on hold on psychometric data or data of drug use from Twitter, because data has cost?
No, yeah. So in this case, this was actually so you might have heard about sentiment analysis, right? So you can do analysis which tells us whether a tweet has a positive, negative, or a neutral sentiment. That is a very rudimentary analysis. The psychometric analysis is where we basically take that one step further and we say that this Twitter data, there can be lexical categories, right? And that is not our work. That is work done by other researchers, and it is called creating lexicons on demand, right? It uses deep learning to, for example, start with some keywords. You can start with malaria, you can start with vector, right? And these keywords, then the deep learning models can suggest, do you want to expand to this category of words or space, lexical space of words? You can say yes, and you can then expand the space of that word. So that's exactly the kind of work that we did, where they showed it for emotions. We also added vaccine hesitancy in the follow-up paper, where we looked at vaccine hesitancy over a period of time. So basically, it was all language patterns that could indicate lexical categories of words like hesitancy or anger, fear, right? And some of these are validated. There's a very standard paper in psychology literature called LIWC, Luke. And that Luke model is the gold standard model for psychometric profiling. And that serves as the sort of benchmark, right? So once you have that benchmark, it's easy to train models and to say, okay, so we trained a model, how well does it perform on Luke? If it performs well, then you know that your model is actually working. So that is the way basically you would train these kind of models on some benchmark data sets and use those for new lexical categories which were not in that benchmark data sets. But as you said, right, that data has cost. Even training models has cost. So, but yeah, so as researchers, I think we do have access to these resources, although not full, right? Twitter has a academic API which gives 10 million tweets per month, you could even use that. But then, as you said, it's a huge cost for data and mining also.
Thank you.
Thank you.
Okay, so I think with this, I know it's more than 1 hour for you. So we would like to conclude the session here, and I am really grateful, and please accept my all the appreciation and thanks from my core of my heart. And this is really wonderful lecture. And with this, if I mean, I think we don't have more question in the chat box. So with this, thank you so much, Tavpritesh. And our next lecture would be from Dr. David Fiddock, who is a known malaria researcher, on the 10th of March. So I request you all to join. We will share the link and other details soon. And this is really good talk, because we are going, the reduction in malaria is significant in India, but the artificial intelligence can play vital role at this important point, where two very important uh, issues here in the diagnostics and the surveillance. So this is going to be really crucial. I'll connect you later with we have some exciting questions for you as well.
Wonderful.
So with this, thank you very much, everyone, audience, and Tavpritesh. Thank you very much. See you soon. And I invite you, Tavpritesh, whenever, I mean, you are in India, you are in Delhi. So please visit us at NMR personally. We are very, good groups of people who might be interested in working with some.
Looking forward to Dr. Sharma. Thank you so much for having me here, and thanks to all the audience for patiently listening.
Thank you so much. Okay. Bye-bye.